Good morning, everyone. Hopefully everyone had a good evening last night, and if you're like me, witnessed the football extravaganza. The only good thing I came out of that is because of my neck size, people thought I was one of the football players standing out front. So I started getting questions and answers, which was really weird, but at least I was able to answer some of them because of my experience. So that was the only benefit of that happening to me. But moving forward, today's panel is really to address and how we improve outcomes for patients with cardiovascular metabolic syndrome. And again, it's really driving and how we look at with the panel and defining multidisciplinary approaches of high cost, high burden of a therapy with outcomes alignment around that. And again, this is highest drug spend that needs to drive measurable value, not just cost. And what we're looking at is to drive how these panel members will speak to around technology, digital health, clinical outcomes, interoperability on the workflows, pharmacy claims, EMR, EHRs, data, et cetera. And it really is getting into how we drive value-based or outcome-based initiatives to prove value. I'm welcome to kind of introduce the panel today and our core objectives of how we define that multidisciplinary approach, and again, explore evolving pharmacy benefit models that kind of drive those aspects with this panel. I'm going to allow the members to kind of do a quick intro of themselves and allow them to give a little background of where they came from and where they're currently at. I'll start with Justin.
Morning, everyone. Justin Simoncini. I'm with U.S. Heart and Vascular. I lead our growth effort. We're a private equity-backed cardiovascular roll-up. We have about 200 physicians and 120 APPs in 5 states. We're backed by Ares Capital Management and Rubicon Founders. So I think one of the unique things about our platform is we are building a value-based care company within the 4 walls of a fee-for-service entity, and really happy to be here today.
I'm Jenny Barlow. I'm the AVP of Pharmacy Industry Relations at Scripius. A pharmacist by training. I spent 18 years as a hospital pharmacist before spending 4 years starting up Civica, the generic drug manufacturer that Intermountain Healthcare started to solve drug shortages. And then I've been at Scripius, which is a mid-level PBM, and do all of their rebate contracting and oversee our pharmacy network contracting team as well.
Good morning, everybody. Simon Salgado, Chief Revenue Officer for WellDoc. We are a healthcare AI-ready cardiometabolic platform that supports PBMs, payers, and health systems to build digital programming to support those members. Prior to joining venture-backed health tech, spent 10 years with Caremark, so I'm a recovering PBM executive myself, but still fondly work with a lot of them. Pleasure to be with you guys this morning.
Good morning. My name is Lisette Lorenzo. I'm the SVP of Clinical Strategies and Services at Abarca. Part of my responsibilities is leading the design and implementation of clinical programs centered around quality measures, cost containment strategies, and disease state management. And I'm also a key stakeholder with our clinical product innovations team, and I represent the business, forward thinking and bringing in technology such as AI and machine learning into our clinical workflows, with the goal to reduce the administrative burden we know we all have with our clinicians, and they can spend more time engaging with patients and focusing on outcomes. I'm a pharmacist by training. I've been in managed care for 20 plus years.
Thank you all, and also thank you from PBMI as well for being here and representing your organizations also this important topic. As you can see, we have a great panel for discussions, so I'll kind of framework our first segment in regards to how we're going to address areas of what we're looking at for cardiovascular metabolic disease. And again, knowing that it's one of the costliest, most complex conditions facing our system. Roughly 1 in 3 adults in the US live with overlapping diabetes, CKD, or CVD, and mainly are on 10 medications or plus, struggling with fragmented care and uncoordinated benefits. So yet, we have current models that still focus on medication access in silos rather than sustained and measurable outcomes. We're going to look really at discussion questions around how we look at rethinking the benefit design, critical integration or clinical integration from that standpoint operationally, and digital enablement not in the silos, but in synergy. So I call it interoperability, how we really look at these areas of focus in the next discussion questions. So with that, my first question actually goes to Lizette. What makes CRM population especially hard to manage under current benefit designs?
Well, first I'll say it's not a simple question to answer, but I will attempt to get this started. I would share that benefit designs, as we know, are primarily focused around the treatment, especially with PBM and pharmacy benefit designs. It's more around centered, optimizing drug costs, implementing utilization control. I think there's an opportunity forward thinking for benefit designs. I don't see that we're taking into account the breakthroughs that we're seeing in technology. So at scale, we can do broader outreach on education, real-time interventions. There's a big opportunity. There's a lot of tools out there that members have access to today where we can leverage the wearables, the digital health platforms, where we have that real-time monitoring. You can see the weight fluctuations, eating habits, sleeping habits, lab values, all this information. Yet I feel in the benefit for these complex conditions, we're not layering in a meaningful way for members to incorporate this technology into their day-to-day lives, that we can take advantage of that information and really connect with the member in a different way. I would also add as another point, which is a passion of mine, I'm sure we're all in these conversations, when you're designing clinical programs, many times payers are looking for short-term gains on drug cost controls, and for these complex conditions, you really have to focus on the long-term benefits of outcomes. So we have a lot of pressure from our payers on the short-term ROI. 12, 14 months, we want to see an ROI in these clinical programs. And yes, you can see that for therapeutic interchange, cost containment at the drug level, but when you're talking about these complex conditions, it takes longer, right, to see that ROI and that benefit. And I think it's something that we need to continue the conversations as you're building benefit designs. How do you layer in these clinical programs that have more long-term benefits? I spoke a lot about technology, and I'll end with the social determinants of health. We know that they're not just background factors, but they're clinical risk factors that we have to take in consideration for these populations, and I don't think that we're there yet fully in how we account for those social determinants of health in a benefit design.
Thank you. Any other panel members want to chime in? I just have one extension of this category, especially around benefit design as it relates to costs, and I open it to Leza or the panel members. And being involved in the payer space, we continue to see it shift in regards to more shift to the employees, particularly shifting in areas like self-insured, TPAs, brokers, et cetera. Any insight around how you or other panel members deal in that market segment? Again, we say payers, but to me, payers nowadays is multifaceted in regards to not just your typical health plan and PBM arrangements. Again, the self-insured markets are rising and really carving out certain areas of high-cost therapies, and I would like your insight around that.
Yep. I could take it. Yep. I think what we're seeing when we're engaging with payers, that the employer groups are more open to these types of clinical programs and engaging with the members differently. I think the bigger payers are slower to adopt these programs.
I'd say at the clinic level, one of the challenges is as the pharmacy spend and medical spend are kind of further intertwined and it becomes more of a out-of-pocket, it's really challenging for a patient to understand where they are. Our doctors don't know, right? We don't know if you're necessarily on a very expensive medication and you've hit your out-of-pocket when they're thinking about polypharmacy patients. It's a challenging journey to navigate. When a patient asks, how much is this going to cost me, which is a very, very common conversation in Medicare and elderly populations, it's a really hard question to answer real time in the clinic.
Thank you. Any other?
I would just add, I think Lizette hit a point on a lot of these are long-term outcomes, and the question is, well, how do I know that we're at least tracking in the right direction? And ultimately, when it comes to the kidney part of cardiorenal metabolic disease, 60 to 80% of individuals will never progress to end-stage renal disease or kidney transplant. Ultimately, many of those individuals are going to pass away from heart attack or stroke. So what can we do now on the cardiometabolic side to help those individuals? The classic reduce A1C, reduce blood pressure, reduce weight. Those are going to be the core metrics that you can work on now to have an ROI for that side of the equation.
No, and Simon, that kind of gets at my next question towards you is really what does the whole person or holistic approach of outcomes actually mean in CRM care. So again, how do we measure it? What the metrics should prioritize? Again, there's certain and many data elements that we kind of look at when we're tracking data, and I'd like your insight on that.
So building on, again, on the cardiometabolic side of the equation, gold standards are reduce A1C, reduce blood pressure, reduce weight. At WellDoc, we have a digital platform with a framework on how we engage individuals holistically. We call it MEDALS. And so for my PBM colleagues in the audience, the M is for medication, E is for education, D, diet, A, activity, L, labs, and S, sleep. And so if you're engaging that individual holistically, we can actually track those different levels of engagement through the application. We connect to over 400 devices and data sources to collect personalized biometric information, and then we can pass coaching back digitally as well as connect to PBM partners. So ultimately, it's not just about moving the needle on one measure. It's about how do I actually engage across these different dimensions of health and empower individuals on meeting them where they're interested to go deeper. They might not be as interested in the labs, but if you can get them getting more activity, that's a good thing. And then you can hook in other elements later. The one other piece I would add is there's a big detection problem in kidney disease. And so to the extent that there's data across the partners in this ecosystem to help, currently 9 out of 10 people who have CKD don't know they have it, a great opportunity for all of us to close that gap.
Right. Any other additional points from the panel? Around data and technology, and I like the panel and even Simon and Justin particularly to chime in here. Again, technology and digital health components and wearables are really stepping into our healthcare ecosystem. So again, that all evolves around how we're grabbing data. The issue is the continued silos and the interoperability of integration within these. How are we seeing that being addressed of the data elements we just went through to grab?
We have a pretty robust remote program, RPM, CCM, virtual cardiac rehab, pacemakers, ICDs. We're collecting on a regular basis significant data on patients. I would say making that data more actionable, sharing it across other providers, even with interoperability and messaging, is still very hard. Other things that are happening, if they're getting a sleep study, for example, from their primary care provider and the cardiologist doesn't always know about that, these are really important connections that are difficult to make. And honestly, the interoperability of these systems is better than it's been. It's still really not perfect. I would say one of the biggest issues that we face day to day is just really understanding every single medicine that's active or that patients are on and that they have in their possession. They're not great actors. It's a daily struggle to get that list right. And I'd love it to be in a magic single digital place, but I don't think that's going to be a reality for some time still, even though we're working on that. So combining that with that remote data in more actionable, interventional, early intervention ways is one of our key tenets of why we kind of exist as a care organization. But it's really, really hard to do, and it's really expensive. And generally, we're not getting paid for it yet today. We're working on that, and that's a different version of a value-based care contract.
Any additional comments from the panel? Okay. Justin gets into my next segment for you of a question that you just kind of went through of, we define nowadays what's truly is the patient journey. So where are the biggest disconnects between pharmacy benefits, clinical care teams, when we're holistically looking at trying to find the patient journey in this disease category?
I think Lizette touched on it really well. I mean, these are 20, 30, 40-year patients. Once you're under the care of a cardiologist, in our case, you're pretty much going to stay under the care of that cardiologist for the rest of your life in some way, shape, or form. What you do outside of that, if the doctor's not well informed, makes it very challenging. Where you're getting other prescriptions, right, where primary care is dabbling in cholesterol management or other very common things, which is it's good medicine, except it's not quite coordinated. That's really, really challenging day to day and can be very expensive and redundant for the system.
Thank you. Any additional points from the panel? My last question for the group on this segment is, what's one risk factor or cost driver in CRM that is being missed by traditional pharmacy benefit design? And I'll start with Lizette and move ourselves down.
I would share that something to consider is post-discharge. We do have programs centered around the post-discharge one-time medication reconciliation, but we do see a drop-off on access and adherence. So you can stabilize a patient in the hospital, they get discharged, they go home. You might have a pharmacist call in, do that reconciliation, but you need that ongoing support once they leave the hospital to decrease readmissions.
Simon?
I'm going to come back to gaps in testing, and I think there's a great opportunity for us to work together to find out how to get pretty simple lab work done, both on the blood and urine side, to find out where people stand.
Right. Jenny?
I think you touched on the benefit design gap really related to high deductible plans or some of the plans that have members having a high cost coinsurance before they get into their, meet their deductible phase. So one thing Scripius does, especially with some of our exchange plans, is have the members get to bypass that. And specifically in the cardiorenal metabolic space, SGLT2s, all the statins, they're all, bypass that and are paid at their co-paid outside of the deductible. So that's a unique thing I know we do at Scripius. I'm not sure if it's done universally, just to help, because there are so many, self-funded plans where they are having to put a higher cost share back on their members, but they're bypassing it in the CRM space because this is such a chronic and high cost category.
Yeah.
One thing I'd say is sort of that regular or more regular clinical consult with a pharmacist based on what medications that you're on. That's not really part of standard benefit design. So we're working on some solutions at our clinics that make it either we figure out a way to cover that cost or we put it into a value-based contract where that is standard of care and that's a regular activity that's happening, which is really not common. So that's for our higher risk heart failure patients, polypharmacy, but that's not something that happens for many patients, even once a year. And I think that's something that could be a significant improvement in benefit design.
Thank you. I'm going to move on to our next framework of questions. And it's, again, getting into that pharmacy benefit innovation. And as we see, more and more that we're seeing more movement in pharmacy benefits, and it's just not getting or opening the door to these meds, but actually driving meaningful outcomes. So as payers are piloting more outcomes-based contracts, and again, this is a very new concept, especially in specialty pharmacy disease therapies, more outcomes-based or value-based initiatives, and how we embed that into the contractual models, tied to kidney function particularly. Others are integrating digital health coaching into the benefit itself. The question is, what's working and where are we still falling short? So my first question to Jenny is, how are you rethinking coverage or strategies for GLPs and other areas like MRAs with CRM therapies? How do you support long-term outcomes rather than short-term utilization control?
So foundationally at Scripius, we're a low net cost PBM, and specifically for SGLT2s, where you get a triple benefit with the cardiorenal metabolic effects. There, we actually have one of our largest downstream clients last year who, with Jardiance and Farxiga, actually chose to remove Jardiance and replace it with Brenzavvy as a preferred SGLT2, and that's a $50 SGLT2, so you're getting the benefit and the cost savings of that. And that plan was actually hoping that would save $1.6 million over annually, and they're already at saving $3.4 million, and you're getting that glycemic control and the SGLT2 benefit. Those members who are on the high deductible, they can definitely afford the $50 a month compared to the Jardiance or Farxiga that they were having to pay out of pocket. So that's, I think, a unique thing where we're trying to balance the clinical evidence of SGLT2s being a great foundational support in this category, but then finding an opportunity for cost savings. And then Farxiga will lose exclusivity in the first quarter of next year. So you really are ramping and saving that plan for even additional savings as multi-source generics come out. Thank you. Any additional comments from the panel on that? I just have one extender on that area, and again, it's for Jenny or the panel, based on your experiences. As we look at benefit design and utilization control that equal costs, obviously, is we're seeing more and more, particularly carve-outs, especially in
working with stop loss or medical group underwriters. Are we seeing more and more of that, or what's your experience working with those entities around high-cost therapies like this?
So I guess I have another example, high cost in this category for GLP-1s that we do uniquely. And because we do direct contracts and with all the pharmaceutical manufacturers, we have a unique tiering in our GLP-1 rebate contracts. We have the typical PA to label or even PA with a step-through metformin, but we have a unique contract that allows downstream plans to utilize an SGLT2 step, a trial and failure of 90 days of an SGLT2 prior to getting to a GLP-1. And so we actually see almost 40% of members that will get glycemic control with that, meaning that their hemoglobin A1C is less than 7, controlled just on an SGLT2 and not having to go onto a GLP-1. So that drove our 2024 commercial GLP-1 trend was only 8% last year in our commercial plans, which I think we've heard trends of 26 to 30% at least in 2024. So that's a unique way we are trying to innovate and still allow access to GLP-1s are still a necessary component, but if you can try and fail on a great foundation of an SGLT2 first, after 90 days, if you're not getting that glycemic control, you can layer on that GLP-1 at that point, but we really have that unique opportunity, and that's because we can directly contract with the manufacturers that are not dependent on just the typical PBM contracts out there.
Great insight. Any additional comments from the panel?
I love that. And we're doing some interesting work on GLP-1 access as well, where we're supporting some of our PBM customers to essentially wrap around the lifestyle digital tools as a prerequisite to step through and get access to the GLP-1 for indication of weight loss. And what we found is it's driving away the inappropriate utilization and ultimately compared to just a more general open access to that medication for indication of weight loss, a 25% reduction in GLP-1 spend. And so it's all about the balance of the access appropriately versus making sure just the right people get the access to the drugs that they need.
Now, great insight and input, and this kind of leads into my next question. I'll start with Lizette. How do we build serum-specific performance metrics into the benefit design, and who should track them?
I think that's a timely topic and one that it has the attention of the White House. If you guys saw the summer press release by the White House, they're doubling down on the next generation digital healthcare ecosystem, and they're calling upon the top leaders, tech leaders within the nation to come up with the solution. So that's at a much broader scope, right, than the conversation that we're having, but we'll definitely be able to tap into that CMS interoperability framework that they're building so that we have less data fragmentation. We've spoken about a lot of solutions that we're each doing as individual organization, more inward, but these are solutions more outward where we can benefit from in the future. So in a true ecosystem of interoperability and leveling up that conversation, yes, we'll have the integration of data for pharmacy, medical labs that we're always talking about, but I think more than having that raw clinical data is how do we turn that into descriptive analytics, predictive analytics, where we can get ahead of these types of conditions and identify the precursors such as obesity, diabetes, hypertension, cholesterol, everything that we're talking about, getting ahead of that and having access to that information. So ultimately, I think everyone's responsible. We're just all looking at different data and we have different metrics that we're measuring to. And we need to unify that and provide meaningful incentives for the overall outcome of that patient and not what just I'm tracking at my PBM and what commitments I have from a performance guarantee level for the payer, but just overall how we're improving the benefit for that member.
Great point. Any other additional comments on? So that kind of gets into my next transition with, I'll kind of poke at Simon on this, is really with digital tools and tracking outcomes, within CRM patients, how do we get there with these type of new engagements? And again, digital technology is really, still at the cusp of healthcare. So I feel we're still in a trust factor and also unraveling the barriers of user-friendly components besides how to engage providers and other utility players of using these type of tools. So I'm interested to see your perspective on engagement with CRM patients.
Yeah, I appreciate that. And I think first and foremost, the digital tools are accelerating quickly. There's a lot of utility that we can get out of them. but they're never going to replace the human touch and that human care point. However, we know that individuals managing these conditions are not going to have access on a regular basis. They can't take their provider with them and meet with them every day. And so that's really the area where the digital tools can be the connective tissue with that care team. And at WellDoc, we really think about embedding ourselves and wrapping around those care teams with our customers and allowing the artificial intelligence that, in our case, actually FDA cleared to do its work. And so I'll provide a few examples of what that may look like. And somebody may be meeting with their endocrinologist for diabetes or their CDE for a program, but when they are transitioning to insulin, they're having a hypoglycemic episode, what do they do? And that's where a tool like ours can take in their personalized biometric information. We connect with over 400 devices and data sources, including CGMs, blood glucose monitors, and we can actually coach that individual in real time on how to take fast-acting carbs. What pictures of what does that actually look like? Set a timer to check and retest. And that's something that we can do with them in real time, in the moment. When it comes to managing kidney disease, being able to surface kidney-friendly recipes to build a meal plan for the week and then actually export those recipe ingredients to be delivered by Instacart to your home. And so those are just a few of the examples where we can help the individual, but also help the provider and the care team as well. And so by collecting all of this information, it's not just about data points, but it's about the insights that we can surface. We know that care teams are stretched thin. They don't have time to reach out to everybody with the same level of intensity. So if we can use those data points and flag those rising risk or high risk individuals, we can make better use of those limited resources, have the care team engage with somebody maybe before their next scheduled visit because we know they're trending in a high risk situation. And then when they do meet with those individuals, being able to have those digital tools actually assemble the data so that we're not having a question and answer session and trying to remember what happened over the last 30 days, but we're actually having the insights at the ready about the actual biometric data points to support that clinician. That's really the power, again, not just of digital for digital's sake, but for empowering the existing care team as well.
No, you bring up a really good point, and my next question goes to Justin around this, obviously from the provider lens, is, we see adoption within the provider clinics or clinician groups. And we're still obviously faxing in prescriptions in a large way, which just astounds me because I've been in this business 28 years, and even when was back in the 90s, we were still trying to move physicians stop faxing in prescriptions. So the adoption in the area is pretty slow. What do you see regards to benefiting, or what benefits innovations move the needle in these provider clinics versus which cause friction in your?
It's a really good question. We have so much variability in step therapy and prior authorization requirements, plan to plan, even within major payers and the subplans. It's a full-time job. And at some point, that friction stops sort of the goal of the physician, which is right patient, right therapy, right time. And they will stop, right? The care teams are stretched thin. Every time when they have to stop and do a very, very complicated or very detailed prior authorization response, they can't do what Simon said, which is reach out to a patient who might need a phone call or a response. So that use of time is probably our biggest friction point on getting the right therapy to the patient. Writing that prescription, even getting it approved, still doesn't guarantee they're going to get it, and still doesn't guarantee they're going to use it. And that's always challenging because you're on a 90 or 180-day kind of follow-up cycle, and sometimes you don't know if that's happened or not. The other thing that I would say is we have miles and miles of runway on full titration GDMT, and that's a full-time job to get patients up to the correct levels and have them seen in a more regular basis. We don't have enough cardiologists, for example, just to do that for the aged population that's continuing to outpace the growth of the physician group. So benefit design or benefit encouragement to help us get there, I think would be really helpful. Either clear markers that you can measure, digitally or through lab data, or clear kind of bundles, which people get used to, right, from a surgical perspective. These therapies are all approved for this condition, full stop, let's move forward quickly, I think would help a lot.
No, and I'll just extend on that too, and I'll leave this for the group as well to chime in. In our world, what we're seeing with provider groups, particularly around technology and enablement, but The reality is, with prior authorization, Lizette, you noted that we need to standardize data formats, and I can't agree with you more, but we also need to standardize prior authorization across the payer spectrum, because even the American Medical Association just noted that a normal clinic will spend 14 to 20 hours per week per PA on getting something approved. A 26 provider clinic will have to hire 8 MAs or 2 biologic coordinators and spend 80% of their job filling out prior authorizations, something that they weren't hired to do. So again, how do we move the needle in regards to disruptors like this in the prior authorization process with provider clinics and technology?
Standardization would be great. I mean, some alignment amongst payers would be super helpful, and more digital back and forth with clear and crisp sort of guidelines. So it is something that you can potentially automate with a smart AI or pull from the record. That is on the roadmap for us, I think. But without the consistency, or unless you have a really, really well-trained agentic model, it's really hard to rely on the technology to do that today. You still need a person to come intervene.
What I would add is, and it was spoken about yesterday in one of the sessions, is how do we tap into the EHR? Because many times you guys are going into the EHR to retrieve information that we might have access to, right? And we look at those codified clinical data elements that we can do what we're calling the touchless PA or the seamless PA, where we can go in, retrieve the information without having to have someone go in there and look at the EHR. There are many EHRs out there, so our struggle as a PBM is how do we integrate with the different EHRs and all the different systems that are out there. So hopefully with the interoperability conversation, having this ecosystem of data, it will relieve that pressure, because we're all trying to find solutions, individual solutions with the individual EHRs to do that touchless PA. And instead of us getting data feeds on medical data, let's have access to the EHR. We can go in there and retrieve the information. I think that's where we need to head.
Yeah, I couldn't agree with you more. I think we're seeing more and more technology, particularly on the provider level, a lot of different companies coming into these clinics and relieving the administration burden around this. A lot of AI is embedded within that. I think still the issue, and Justin, you alluded to it, is we can't totally trust it. I think their AI is going to be really modeled towards simple tasks in regards to what PA, but when we move, and I love the panel's insight to this, is when we move to a second or third level appeal medical necessity, that's really where we still need like a biologic coordinator to kind of go into the EHR or EMRs and really pull certain information, because AI is just not ready for that. And like I said, I think what we're seeing is more and more AI enablement in this more task-oriented, but it's still not the resolving factor that we have to work on these appeals or medical necessity requirements based on payer policy or the prior authorization itself. I'd love your input around that.
I would share, even before AI, there's information that we're collecting on the PA that's just lab value, hemoglobin A1C, diagnosis code, that we're calling in to get that information. We can readily access it. So I don't know that we're with AI yet to make this clinical decision making. We still need that clinician to do that information, but to get these lab information, diagnosis codes, many times we're calling to get an information that at the office, you're just logging in and telling us a value that's in the EHR. We need to get there first and then get into the whole AI conversation.
Totally agree. Any additional comments from the panel?
Yeah, I think standardizing a set of data that is interoperable and agnostic to the system. Yep. So every clinic, PBM, payer, it doesn't matter. We need a standardized interoperability of data exchange. And then from there, I actually think innovation will take off tremendously, but we need that standard first.
Yeah, and I think this kind of gets into my last question for this group on this second framework, is the more and more we see and discuss outcomes or value-based agreements, what models are we seeing tied to these areas, especially with CRM, based on success or even gaps? I'll start with Lynette and kind of move down.
I always share that I don't think we're seeing these value-based contracts at scale yet. And for us as a PBM, just for simple hemoglobin A1C, trying to get those values, right, for those contracts can be very challenging. Again, it's very fragmented, and we can contract on behalf of the payer, but then we need to receive that information timely from the payer to be able to act on these value-based contracts. So there are opportunities, but definitely not at scale on what we need to see to really drive incentives for our clinicians, our pharmacists, and physicians.
I'd say we've gotten closer, but there's a long way to go. And so at WellDoc, we built mechanisms to connect into labs to solicit those values from LabCorp requests, and we can pull those in for A1C, other labs, and we're actually using those to work with our partners to drive smarter prior authorizations. But long way to go. I think today the contracts are a little bit more based on, hey, can I move that needle on A1C or weight or hypertension? What's the research-based economic value of that? I think that's as close as we're seeing, but I think there's a lot of opportunity to get closer to the actual reduction in medical costs.
I can echo what Lizette said. It's hard to put into a contract when you can't have the data timely enough that pharma wants it to be able to get an agreement in place.
It's a little different for us. So two things. One, limited risk contracts are fine, up and down a couple of percentage points based on outcomes, but they're not that exciting, and the dollars aren't really motivating for changes in care behavior. Full risk contracts are great, and they're out there. I think the payers are a bit reticent to actually engage in, the sharing of savings in a meaningful way, which also makes that challenging. And from our perspective, when we do that, we're carving out expensive drug. Like not necessarily what it should be, but in order to meet some of those goals, we have to carve them out, or one or two, very expensive patients can blow your whole model, right? And that makes it really, really challenging when you're thinking about trying to do the right thing from an outcomes-based, value-based care, contract adjudication. We don't have the same issue. We can provide data pretty real time, right? We can have a back and forth with payers. They do not act quite as real time as you would like when it comes to the interpretation of that data and sort of that 90 to 180-day claim review cycle that they go through. And again, I think there's a disconnect there when we're designing that value-based program.
No, those are all great comments, and it kind of sets in to our last framework and really looking at a multidisciplinary collaboration to be in sync. So as we know, CRM care touches, and we've heard it today, not just cardiology, but nephrology, endocrinology, pharmacy, and digital health. So unless pharmacy benefits enable these stakeholders to work in sync, as we just went through, we're left with fragmented care at the end of the day across the patient journey. PBMs often serve as data centers, as we all know, but how do we make that actionable? So my first question around that framework is to Justin. From the provider network lens, how can we benefit design and ancillary support ensure success in value-based pathways for CRM population? And again, any examples where alignment, improved outcomes, or total cost of care from your perspective?
I think it's really hard. It's a diverse specialty. Looking at something like heart failure, I think there's reasonable metrics that can align across specialty care, right? So you're looking at blood pressure, you're looking at weight, you're looking at ejection fraction, you're looking at, overall, retention and how many times patients have had to have, maybe not admission interventions, but near admission interventions, and how do we prevent more of that? How do we coordinate all of the information that we're collecting from remote programs and share that with the other clinicians? I don't know if that necessarily flows through the pharmacy benefit, but I think feedback from the pharmacy benefit on if there was a prescription or something happened in between visits, that would be really helpful to the care coordination. And again, that doesn't happen in real time today on a regular basis. It happens sometimes with engaged patients or really, really active kind of primary care or other providers, but it's not an everyday occurrence.
And Justin, from your perspective too, and experience, not just with your current role and responsibilities, but across your background, and I open up to the panel, are we seeing a difference in how we drive these type of outcomes or total cost of care management when we're dealing with private equity-owned provider groups versus health system-owned provider groups?
It's a good question. I think the goal of most large private equity-backed groups is to deliver higher quality, lower cost care, generally. I don't think that's always the message in the market, or that's not what you hear a lot, but that's the goal. I mean, especially in cardiology, there's a lot of opportunity for site of service shift. There's a lot of opportunity for significant early intervention and actually increased diagnostic opportunity in this specialty that I think we believe in. The hospital groups, you know, it's very different. I think the hospital admission in cardiology is still a very valuable admission. So there's a tenuous line there sometimes versus, you know, keeping a patient out of the hospital for the total cost of care concept. And, you know, I think it's an okay thing in the world that we deal with every day, but that's not totally aligned across the continuum of a patient's journey.
Any other additional comments from this panel on that? I think that kind of gets into my next segment of a question, and this one's to Jenny. Can you share an example where PBM worked with a health system or provider network to align on pharmacy benefits with CRM? Again, what is particularly the key success factors, and could it be scaled?
Yeah, so Scripia's worked with a large nephrology clinic to put a shared service agreement in that really was tracking and preventing chronic kidney disease patients to progress to stage 3 or 4 kidney disease. And when we did that, we actually had to, like Justin said, you have to really look at the drug cost is a part of that, and we actually had to bump up their PMPM allowance in the category to really ensure that patients could get on drugs like SGLT2s earlier in treatment and prevent them progressing through the treatment. And it's only about 18 months in, but we're over 90% of the stage 1 or 2 patients have remained in stage 1 or 2 and have not progressed on. And we've realized about 15% decrease in a total cost of care, and that's a shared savings that is shared back with the provider group in a quarterly payment for them. So we're seeing that could be scaled right to cardiology or another service line for sure. You just have to make sure that the incentives align, and I think it does need to be a shared savings model so that there's equal skin in the game, and it's not just like a decrease in the overall spend.
That's great insight. Any additional comments from the panel on that? So it kind of gets into my next question. I'll push it over to Simon. So, you know, Simon, as we look at, you know, digital health and technology, not only how we place this structurally into provider clinics and PBMs and other elements of our healthcare ecosystem, but culturally for PBMs, what needs to be done to collaborate effectively? You know, again, we get into, you know, really restrictions when we're working with large provider groups, not only with pharma as a class of trade, but anti-kickback, stark laws, what providers truly want to pay for and what they don't. How do we embed that integration into their clinic practice with patient engagement, you know, attach to their EMRs? There's all these sensitivity factors of how we drive that effectively. So how do we overcome these barriers like data silos and integration challenges?
Oh, just a softball question. Okay. Well, I'll build on Jenny's point first. So we are definitely an enabler. When we work with our PBM partners and other partners, we are part of a broader program. We're going to be that digital extension of that. Maybe it's the pharmacy team, maybe it's the provider team. And first and foremost, to build on Jenny's point, you got to make sure that the incentives are aligned, that there's skin in the game on all sides. And for us, we're going to put our money where our mouth is in terms of being able to drive outcomes, but we need to make sure that we've got the volumes to be able to demonstrate that at scale. Ultimately, when our partners come to us, they're looking to collaborate to accelerate or build a program homegrown for the most part. And so they're not just looking for something that's turnkey out of the box. And what that means is that there's going to be extensive collaboration on objectives for that project, who owns what swim lanes, how we're going to share that data so that ultimately we can build a program that's going to be jointly successful.
Great point. My last question around this segment is to Lizette. Are pharmacists really being activated effectively in this CRM focused benefit, or is it still under scrutinized? You know, again, what changes in the benefit would unlock more value for pharmacists in CRM care?
I would say yes and no. We're seeing pharmacists are being utilized for the individual disease states for CRM, primarily around diabetes, hypertension, cholesterol. We're seeing pockets of that even in the retail space where there's programs out there to incentivize pharmacists to engage with this population. But it's more centered around therapy optimization, right, and adherence. There's a lot of programs around adherence for these programs, for these disease states, but we're not leveraging the pharmacists more broadly for these complex conditions. Justin, you spoke about it earlier. You see the patient 90, 180 days, like who's working with that patient in the meantime to titrate these therapies? And if we can expand the pharmacy benefit design to engage pharmacists and have them support in titration and oversight of their drug therapy, not just in the inpatient setting, I think it happens there, but outpatient, how can we engage our pharmacists to be more involved in these complex conditions and not siloed of, here's a diabetes program, here's a hypertension program, I'm going to reimburse you for adherence and outreach and CMR completion rates, but more involved in the overall therapy for these patients.
Great point. Any additional comments from the panel? As we kind of, set some time for Q's and A's, I leave each panel member with this last question. It's kind of a dual question in regards to, so I apologize, I have to because we're so entrenched with policy up on the Capitol Hill, is what wish lists of policy change tomorrow do you see and would like to see in CRM care? What would it be? And then with that, what must stakeholders do differently to have meaningful movement of or moving the needle in CRM care? I'll start with Lizette.
I would start with the pharmacists, like how can we, in a meaningful way, bring in pharmacies into that interdisciplinary team in an outpatient setting where there's a reimbursement model that really takes into account the high-value service and the value that pharmacists are bringing to this population.
I'd say from a policy perspective, you may not see the outcomes immediately, so how do we sort out the reimbursement to incent the work that needs to be done to get those long-term outcomes?
And the policy I'd love is to mandate data interoperability so that pharmacy, lab, medical, wearables, all of the data seamlessly transitions to the appropriate stakeholders.
I would say payment-related policies, so making it easier for patients to understand what the cost drug-to-drug or plan-to-plan is as they fill. It's so confusing and complicated for them. We don't have time in the clinic to be kind of payment counselors, which is really challenging because it's a big part of the conversation. That would make our life and I think our treatment journey a lot better if it was a little bit easier for patients to understand and they would have a much better experience.
Thank you all. Is there, at this point, any questions? If you can, move up to the mic and we can have the panel address those as they come up. If not, everything must be submitted in writing in after 1 minute. All right, so I leave everyone with this. I thank each of you. Great insights today on this topic, and again, some good key takeaways, not just for CRM, but I think as holistically we look at digital technology and collaboration amongst providers, payers, and PBMs. And as I said a lot to folks last night, I'm not taking autographs after today, so please leave a card with me if you want something afterwards. Thank you, each of you, and thank you for the attention.
Thank you.